it is an ICU with a history and a present and a future, and that's what I want to discuss. Basically, critical care is a specialty that came about approximately 60 years ago in the 1950s. At that time, it was kind of a primitive specialty, and the specialty sort of kind of had a grassroots and kind of was developed by the physicians who practiced it. The first unit at Quinte Health Care opened in 1964. Prior to that, critically ill patients were essentially taken care of wherever they were, where they might have been on the ward, they might have been in the emerge, they might have been in a crowded corridor. That's where they were resuscitated if they had a real problem. Dr. Bruce Kronk, an internist, he was one of the key people in organizing the opening of the first unit in 1964. And if you look at that date, we're going to be hitting the 50th anniversary of that this coming year. And I have to look up the, we'll have to hit the archives to find the exact date so we could celebrate it. At that time, it was kind of an open sort of ward. There were no partitions between the beds. It was 9 beds, no cardiac monitoring, no respirator, limited technology, and lots of homespun innovation by doctors who were essentially acting as medical engineers. So, it must have been a happy day when they got their first technology, the first respirator, what we now call a ventilator. This is called the Bird respirator, and when I looked up in 1964, this would have been a Mark 7, and this is in fact a picture of a Mark 7. It was invented by Dr. Bird, who was the person who designed the first respirator, and he's got a great history too. This was purchased through the efforts of another doctor at QHC, Dr. Woodley. Unfortunately, the nurses knew very little about its functioning. There was no such thing as respiratory therapists, and so the physicians had to really run it when it was required. It's not advancing. Okay, so the early years. With time, we did purchase more technology, the first cardiac monitor, the first defibrillator, and something called a heart-lung resuscitator, which is a machine that no longer exists, but used to do chest compressions and sort of breathe for the patient at the same time. By 1969, there were significant advances in critical care, and this coincided with the opening of the new building and a physical structure, which was what we call the old unit, an 11-bed unit next to the recovery room. This contained both medical and surgical patients, plus a 4-bed CCU. It operated as one unit in conjunction with the surgical recovery room, and 4 internists, Dr. Kronk, Loynes, Totten, and McIntosh, were involved in its early organization. By the 1970s, the number of patients requiring monitoring had risen dramatically, and coronary disease even then was on the rise, requiring that all the beds in the ICU become monitored beds. So by 1979 that had happened, and also in 1979 the ICU and the recovery room separated and became autonomous units. So here's a picture of the old recovery room. And that's a picture of our very own Dr. Curry Grant, who's now in the stroke prevention clinic, but a cardiologist who acted as both an internist, a cardiologist, and an intensivist. And here he is, I assume, in the early 70s with a patient. So what happened in the 80s and 90s is that respiratory care expanded, and the first telemetry system was bought. That is a system whereby the cardiac monitoring is transmitted electronically and can be monitored remotely. And during these years, there was an explosion in critical care as a specialty. The role of the intensivist and specialized critical care nurses and specialized respiratory therapists that were trained in critical care and other specialists, the importance of them at working as a team to promote the care of the patient became recognized. Also, in 1992, I believe it was, the Royal College of Physicians and Surgeons of Canada recognized critical care as a specialty. And we now have what are known as intensivists, that are doctors that take care of patients in the ICU and are specialized to do so. At the end of the 90s, in 1998, a very historic day for Quinte Health Care, as our 4 sites amalgamated into one hospital. By the turn of the millennium, critical care was a specialty unrecognizable from 40 years previous, both in terms of technology and expertise. Evidence-based medicine had forced a rethink of many of the accepted practices. There were well-designed, large-scale clinical trials that evaluated the established procedures and realized that some of the stuff we were doing was quite wrong and redefined a new standard of care. Research revealed that the so-called closed units with intensivist and specialized nurses and specialized team members taking care of the unit were associated with better outcomes. But before that, there were no such thing as closed units. It was all open units where the primary physicians each took care of their own patients, and there was no real specialized team. So, you know, as the evidence mounted, QHC looked at going to a closed unit ourselves. So prior to October 1st, 2010, there was no real comprehensive critical care program at QHC, and that's not that long ago, obviously. We had our 11-bed unit at Belleville, we had a 4-bed unit in Trenton, and we had a 4-bed step-down in Picton, all operating under an open model, whereby the patients were managed by their primary admitting physicians, typically internists and surgeons, but there was no real team approach. It wasn't a comprehensive critical care program. So the physicians and surgeons at Belleville and the other sites started calling for a development of a closed model ICU. This is an ICU, like I said, that's specialized and intensivist-led and high intensity. And that's how they're referred to as high intensity ICUs. So finally, towards 2007, it was decided to strike a critical care committee for QHC. I was its first chair, and it was struck with the purpose of developing an intensivist-led model for QHC. I took on the role as the physician champion for this closed unit, and actually spent several years along with key people throughout the corporation lobbying, proposal writing, and making preparations. By the spring of 2010, provincial funding came through. That's really what we were hanging on, and we were able to hire our first intensivists. And the Division of Critical Care, which didn't exist, was approved by board. And critical care services were centralized at Belleville, and the newly constructed ICU was opened. And then the really happy day, October 1st, 2010, was the launch of the first day of our intensivist-led ICU. And here you see the then critical care lead, Dr. Samus, the team leader, Christine Wilkinson, all key figures in that in the early days there. And here's our ICU team in action on day one. Actually, this is 8 minutes after the strike of 8 a.m. One of the patients crashed, and Dr. Hollett happened to be there and is happily providing medications to that patient. And here is the team actually rounding on that first day. We did try and document that well. These are the first folks that were hired as intensivists. And this is meant to remind me to explain that intensivists come from all sorts of backgrounds. So Dr. Leung on the far left there is trained as a nephrologist. Dr. Samus is trained as a surgeon. Dr. Hollett is trained as a cardiologist. Dr. Kyra Mentang, who's no longer with us, is an internist, as am I, and Dr. Heffernan, who's moved on to Queen's, a respirologist. So what is going on today? So there have been many, many changes since day one of our intensivist-led unit. Each day we note increased acuity, increased complexity, and volume of patients. We have adopted a multidisciplinary approach to care, and we are striving for continued quality improvement. And our goal is not only to meet, but to exceed provincial and national standards. At present, we have 14 funded beds, and we are also funded for 9 ventilators, and what you'll hear about later, 5 BiPAP machines. Our occupancy rates on average are 90 to 100%, but in the last couple of weeks it's more like 150 to 120%. And our ventilator occupancy is within a provincial average of 40 to 60%. And again, this past 8 weeks it has been over 100% or near 100%. We are also running a successful acute stroke program through the intensive care unit. It's actually housed there, and hopefully there'll be another cutting-edge presentation to talk about acute stroke. And so, who is it that we serve? Well, with pleasure, we serve patients from all our sites, So the majority of the patients come through the 4 emergency rooms. And then the remainder are either people who deteriorated because or emergently went for an OR and required ICU afterwards, or transfers from the ward, or external transfers. Our age distribution is essentially adults. So we have no one under the age of 16, and we have greater than 90, and that's not uncommon. And just to show you the breakdown of where our patients are from, we serve about 1,000 patients per annum, and those are mainly from Belleville, but also from Trenton and Picton, and you can see the breakdown there. You might be surprised to know that we do receive some patients from outside the region, and we do accept patients via the service called Critical, which is sort of a dating service for critically ill patients and beds. Anyway, the admitting diagnoses that we see, as you might imagine, are primarily heart and lung. So 42% of the patients have respiratory diagnoses, 33% have cardiac diagnoses, and 12% GI, and then the others break down from there. So what does the future hold? The future, as we know, holds an aging population. We expect ongoing volume, acuity, and complexity of the critically ill patients. And we believe that ICU will occupy an ever-increasing role at the center of acute care. One can imagine, as as throughout North America, really, hospital beds are closing, but the proportion of ICU beds to those is increasing. And so, if you look at it, in the yesteryear, the ICU was 3 to 5% of hospital beds, whereas in the future it's projected to be up to 30%. So specifically at QHC, what does the future hold? Well, we would like to expand the service of the ICU beyond the physical walls of the ICU, and that has occurred at other hospitals, but hasn't occurred yet at ours. For example, we want to develop rapid response teams. These are teams that sort of race to a crashing patient on the ward and try and avert a bad situation, or that will go up there and make sure they receive quick care before deteriorating to the point that a code has to be called, and you'll hear all about codes in a moment. We are also trying to develop areas of excellence. So it's not enough to just meet the standards of care. You want to become excellent in certain areas. And one we're looking at is end-of-life care, which Dr. Harrison will talk about. Another way of moving outside of the unit and having good care outside of the unit is a step-down unit. This is a place to which patients can be discharged or admitted when they don't quite need an ICU, but they need something more than a ward bed. And hopefully we'll be looking at that in the next few years. Information technology continues to advance, and we are moving towards a paperless system. We're really almost there. And basically our focus is not only on optimizing our technology, but our human resources. We have physician wellness campaigns and try and improve ourselves by continuing medical education, such that we are always on the cutting edge.